My name is Professor Louise Hull, and I've been asked to discuss a health challenge that we need innovative solutions for. Today, I'd like to discuss endometriosis, and this is a health challenge that affects 1 in 7 young women in Australia. Endometriosis occurs when the tissue lining the womb, or tissue like the lining of the womb, grows outside the womb. The problem with that is when you get your period and the lining of the womb responds to hormones, the cells die and they leave your body. But when those cells are up in your pelvis, they respond to the hormones by dying. And those dead cells engender an immune response where the white cells in your immune system are attracted to the cells that release chemicals and cytokines and chemokines, and they create an inflammatory response. And you get bloating and pain and heat as well. And that inflammatory response then activates nerves. And the dorsal root ganglion in your spine gets activated. And that starts a process of a potential complex pelvic pain. So with repetitive pain triggers every month, you start to get back pain. Then all the organs in your pelvis get sensitized and you get bladder pain, bowel pain, and pain with intercourse. After that, the pelvic floor muscles contract and tighten in response to pain, and that causes shooting, stabbing, sharp pain. That's often really disabling as the muscles respond to that pelvic inflammation and pain signaling. And that's called somatic pain. Finally, all those pain triggers go to your brain, and your brain gets overwhelmed by them, and you get fatigue, headaches, nausea, feeling hot and cold, and often you wake in pain in the middle of the night and you get very tired. And that's called central sensitization. The other thing that occurs when you've got an inflammatory environment in your pelvis is the environment that the eggs are in is affected by it. And people often find their egg numbers are a bit low, but also if they try and have a baby, the eggs, the sperm, and the embryos have to manage a very inflammatory pelvic environment and have to fight their way to create an embryo and to have implantation. So fertility can be affected as well. So it's a significant problem that affects a very large proportion of our population. And for young girls in pain, often they have to miss school. It then goes on, they get further and further behind and they lose their social networks. And that can impact on their ability to get a job and their socioeconomic status. It can impact on sport and activities they want to be involved in. It impacts on relationships and it causes sexual difficulties. And it also means that they can't do things for some days of the month, even in terms of supporting their families. Finally, it can really impact mental health. And a lot of people find they get very depressed or anxious, and that's part of sexual sensitization, but also it ends up being part of their lives. And it's a big problem that can really impact a lot of people in society. One of the questions is, who are the clinicians involved in treating this condition? And one of the big problems is that often people go to see a clinician and they don't recognize the condition, they normalize the condition, and on average, it takes about 6.5 years for people to get a diagnosis after they have complained of pain symptoms, and they've usually seen at least 6 doctors in that time. So there's a real problem getting their condition acknowledged, getting their condition diagnosed, and getting it managed effectively. The clinicians that people see are often general practitioners, and general practitioners often don't have the knowledge and awareness and tools they need to help people with this condition. People also have to see a variety of clinicians. So they would need to see a gynecologist to traditionally get a diagnosis, because that diagnosis was made at surgery. And surgery is expensive, it's costly, it's risky, and often it's difficult to get a referral to a gynecologist. And certainly there's a long waiting list in public, but also young people can't necessarily afford to go privately. And so there's another delay there. And people have to weigh up the risks of surgery and the time that you need to go through it with the benefits of surgery. And some of the time, endo is not the pain trigger. There are other pain triggers, and they've been through a surgery without having a benefit. We don't have good workflows. All our trials have been done on people who are surgically diagnosed and partially treated. So we know a lot about what to do after surgery. What we don't know is how to look after people in an evidence-based way before they've had surgery. And we don't know the best drugs. We don't know the best ways of treating endo. We trial lots of different drugs often, and lots of different therapies. We sometimes use physiotherapy for pelvic floor pain. We refer to gastroenterologists. We refer to pain specialists. We refer to surgeons. We refer to psychologists for social and psychological support and management of anxiety and depression, which are all part of endometriosis. We also need nurse health professionals to coordinate those large groups of health professionals, and having a much better clinical work path would really help people. But at the moment, it's very much individualized and very much depends what you can access, which is very costly for people. The 2 or 3 key problems, I believe, are in this area. Mainly the fact that a lot of people find their pain is normalized, and they get told it's normal, that this is what women experience. Sometimes their family has undiagnosed endometriosis, so they don't get an answer. Some people are given an unexplained fertility, which is undiagnosed endometriosis. We have a lot of unknown diagnoses, which quite often are undiagnosed endometriosis. So, and people say that the pain is normal. A lot of clinicians don't recognize the secondary pain symptoms, so they can't put together a headache with bowel problems with period pain. And they seem to be in 3 different organ systems, where in actual fact, it's a neural system that's been affected. The second thing is we are terrible at diagnosing endo. We have to have surgery, which is expensive and risky, and not many people want to do it. And it has to be at a tertiary care level. So you've got to get a referral into a gynecologist, and there simply are not enough gynecologists in Australia or the world to perform a surgery on 1 in 7 people. Because of that, people don't get a good diagnosis, and they do sometimes get a presumptive diagnosis, but it's all very uncertain, and it's hard for them to access care and the care they need without some kind of diagnosis. And almost all our other conditions can be diagnosed in primary care settings. We have had some progress in diagnostics. So the European and UK and Australian guidelines have now accepted that very good and specialized endometriosis ultrasounds, transvaginal ultrasounds, and MRIs can detect endo in arrears with about a 98% certainty if we see a lesion, but it does still miss, they do still miss endometriosis. So a negative scan still means you have about a 35% chance of having endo, although this is getting better. The difficulty is that we simply do not have people who can perform those scans. They're very specialized scans, and you need good training, and you need good training to read MRIs, and MRIs are very expensive and not accessible in primary care, although transvaginal scanning is, but they're not rebatable. So it's hard to get those scans, it's hard to read them, it's hard to get people to do them properly, and there's a lot of solutions we need there. The final final issue that we have is we really haven't done any randomized controlled trials or assessments of pharmacology. There's outside of surgery. Additionally, there's been very poor resources put into endometriosis research. So we've had the first drug come onto the TGA approval list in 13 years, simply a week ago. And there are a few more drugs in development, but it's taken a very long time for people to understand that there's a real need for choices for women with endo, and that they don't have good choices. And we've had to work very hard to get medications that allow people to use different options. And there's been very poor development in the area, partly because of lack of funding, but also because we've simply not been able to work out the best care pathways with the uncertainties around diagnosis and the inability to randomize outside of surgery. So there's several big, hairy challenges there and that need really creative solutions in this field. And I hope that you can come up with some wonderful ideas. Thank you.